Thank you for that introduction, Dr. Dattilo. I just wanted to clarify. So I am internal medicine trained and also did a subspecialty in rheumatology at the University of Pennsylvania. Worked in rheumatology for a few years with Intermountain Healthcare before deciding to join the Bateman Horne Center. We are a nonprofit that focuses on research, clinical care, and education in the illnesses of ME/CFS and fibromyalgia in particular. ME/CFS, for those who are unfamiliar, stands for myalgic encephalomyelitis, and chronic fatigue syndrome are the former names. And we kind of combine it now to ME/CFS as sort of the current nomenclature for this illness. And I think it's a particularly salient topic right now because there's a lot actually in the news about ME/CFS and its relationship to the experiences that people who are infected with the COVID-19 virus are experiencing in the long run. So people get infected, they'll clear the infection, and they'll have a persistence of symptoms for 3, 4, 5 months. While that's still early in the course of the illness, a lot of those symptoms in these long haulers, as they say, look a lot like ME/CFS. So I think this is something we're going to be seeing a lot more of in the medical literature, in the news, which for us, we think is a silver lining to this outcome. But I wanted to also, as Dr. Dattilo brought up, kind of go over the overlap between what we see in our patients in ME/CFS and a lot of how they get interpreted by other physicians and then often sent to behavioral health for treatments. So I wanted to kind of just use this as an opportunity to kind of point out some of the overlap and see if we can maybe recognize a few more cases of ME/CFS. So this is a multi-system illness, and essentially the question I want to ask is, could we be under-recognizing this illness in the patients we see every day? I have no disclosures other than perhaps as a rheumatologist, a healthy skepticism for ANA testing. It is not the end-all be-all. Oh, and my other disclosure is that I have a few clip arts in here that I was unable to scrub the watermarks from, but I liked them anyway and used them. So I wanted to, instead of going through aims for this talk, just really start with a patient presentation and then let it evolve from there. So here we have a 31-year-old female that's coming to us today, and her chief complaint is that of seizures and of increasing diffuse muscular pain. Getting into her history of present illness, she has been noting nausea and anorexia, particularly earlier in the day, and then took a nap because she wasn't feeling so well. But after that nap, she got up, felt a little sweaty, and decided she'd try to feel better by taking a shower. During that shower, she noted increasing nausea. She started having chest palpitations, facial flushing, and noted increasing anxiety, and actually ended up stopping the shower or aborting the shower just 1 to 2 minutes in. As she stepped out of the shower and stood in front of the mirror, she tried to dry her hair off a little bit and began to experience moderate amplitude tremors, as she described it, in the bilateral upper extremities and within the neck musculature. She became disoriented and a little bit unresponsive to her nearby husband who was witnessing the event, and then ultimately had an episode of syncope where she was witnessed to have bumped the side of her head on the edge of the bathroom counter during that episode. She did not experience any true loss of consciousness, and the duration of the tremors prior to her syncopal episode where she hit her head was about 30 seconds in total, as estimated by her husband. For 30 minutes after the event, she had some post-ictal confusion, definitely had trouble coming up with the words she wanted to use, and was a little disoriented about where she was and what the day was. Didn't remember all the events leading up to the syncopal episode. She did not have an aura. She had no loss of bowel or bladder continence, no tongue biting. She had not been started on any new medications, supplements, was not using any illegal drugs, tobacco, or alcohol, at least per her report. Some background history on this patient. So over the past 2 years, she had experienced perhaps a total of about 10 similar episodes, although they were a little more mild, where she would notice tremor. She just didn't experience syncope after those. And that's usually because as she started to note those tremors, she would immediately lay down, feeling poorly. She had recently experienced a non-febrile upper respiratory illness with rhinorrhea, sinus pain. She thought she had some cervical lymphadenopathy and cough in the setting of a known sick contact, being her younger daughter. She was experiencing a stressful home situation due to increasing medical bills. She had been seen by a lot of doctors and a lot of specialists for a constellation of symptoms that we'll get into a little further. And she'd also been stressed because her grandmother recently passed away, and her grandmother was as much of a mom to her as her mother was. Her past medical history, as defined by her primary care physicians, included depression, chronic pain and fibromyalgia, generalized anxiety disorder, chronic migraines, a history of panic attacks, ADHD, dysmenorrhea, interstitial cystitis, IBS, restless leg syndrome, eczema, Raynaud's, exercise-induced asthma, and seasonal allergic rhinitis. She did not use alcohol or drugs. She almost never drank alcohol. She did not use tobacco or drugs. She almost never drank alcohol because it actually made her feel sick. She was a gymnastics athlete when she was very young, but after grade school, really wasn't able to participate in sports anymore, didn't have as much interest, and they didn't always make her feel good. She completed an associate's degree and worked at the front desk in a chiropractic office for a few years, but had retired from that temporarily and was working as a homemaker for her husband, 2 children, and 1 dog. She had had a cholecystectomy and a fracture of her left foot. Her father had prostate cancer. Mother was previously diagnosed with chronic fatigue syndrome, and she had a sister with an anxiety disorder as well. She had a pretty extensive medication and allergy list, which I would imagine is not foreign to any of us. She was using Wellbutrin, rizatriptan, lorazepam as needed for panic attacks, hyoscyamine for her IBS, dexamphetamine for ADHD symptoms. She was on an oral contraceptive pill and quite a few supplements that you can see there. And her allergy list included SSRIs, Buspar, topiramate, alprazolam, some antibiotics, modafinil, and actually included a lot of things from her environment as well, including some food allergies and allergies to, or sensitivities to chemicals, with a few interesting ones like Play-Doh and Jell-O and Band-Aid adhesive thrown in there as well. So quite a few perceived allergies there. She was sent to cardiology for evaluation after this event. She was found to be afebrile. Her heart rate was 107. Blood pressure was 102/68, respirations 14, and she was found to be satting 97% on room air, thought to have a normal heart and lung physical exam. There was some laboratory workup done at the time. She had a full comprehensive metabolic panel that was completely normal, no electrolyte abnormalities, a normal CBC, low inflammatory markers, so ESR and CRP were unremarkable, CPK was unremarkable, no elevated troponin, TSH was normal, prolactin was not elevated, and was found to have an ANA because we always test ANA, but this is 1 to 80. She was thought to have sinus tachycardia on EKG and underwent a 48-hour Holter monitor that showed episodes of sinus tachycardia, but had no underlying arrhythmia. She had a normal transthoracic echocardiogram, and she was ultimately told that the syncopal episode was not thought to be cardiogenic in nature. She also went to see our friends around the corner in neurology. They spoke with her about her incident and spoke with her husband about what he witnessed and thought that the tremors were not consistent with traditional tonic-clonic movements. She had a normal neurological exam within that clinic visit. She had undergone a MRI of the brain that was unremarkable for masses, for demyelinating disease. There was no mesial temporal sclerosis. She had a EEG study that did not show epileptiform activity. They did not feel there was indication for video monitoring unit epilepsy evaluation. They gave her no limits on driving, and they did not prescribe her any anti-epileptic drugs. And at this point, she was asked to consider seeking care from behavioral health. So now she's coming to the behavioral health office, and we are tasked with taking care of her. And I think a lot of us are wondering about the possibility, or potentially are wondering about the possibility of pseudo-seizure at this point, which is also known as psychogenic non-epileptic seizure. So The general recommendations for a patient like this coming in, and the group here may actually know more than me about this specifically, but in my reading, the recommendations about what we can do for this patient are to take a good psychiatric history and to focus specifically on what other comorbid conditions may have contributed to getting to this point. And the most common comorbid conditions found in psychogenic non-epileptic seizure include depression, anxiety, somatic symptom-related disorders, dissociative disorders, and even personality disorders with a focus on borderline narcissistic, histrionic, and antisocial personality disorders. Some providers may elect to perform neuropsychological testing, although it's not required. It may be helpful, specifically in looking at those comorbid conditions. We are encouraged to offer a non-judgmental diagnosis. This is always a challenge when you talk about something like psychogenic non-epileptic seizure. And then as far as treatment is considered, other than looking at comorbid conditions and treating those, there's been some evidence suggesting benefits with cognitive behavioral therapy and with other modes of psychotherapy. So let's say we are that provider and we want to go through and kind of screen for depression. And I realize this is a bit of a cursory approach to screening. We're not, obviously the work that we do, especially that you do in behavioral health, is a little more in depth than this, but just for the sake of going through, I wanted to look at criteria for depression as well as some other illnesses and see which ones applied to our patient. So going through the DSM criteria, our patient does feel depressed most of the day or nearly every day. She feels very sad and hopeless about her situation, in particular, the situation that she is losing function and feels like she's losing control of her life due to the things that she can no longer participate in. She does not have a loss of interest in doing things. She says she physically can't. She's too tired to do things, but she wants to do the things that she used to be able to do. She has noted changes in weight, and in particular weight gain, despite, like everybody always says, I'm eating less than I ever did, but I'm still gaining weight. She has noticed that. She struggles with insomnia at night, can't fall asleep at night, but then spends 14 to 16 hours in bed a day in the last several months. She's been noted to move very slowly with a lot of different activities, and in particular, even getting dressed or bathrooming and showering in the mornings. She has a ton of fatigue and lack of energy, and that's really her biggest complaint overall among all of her multitude of complaints. She's beginning to feel worthless. She's not able to take care of her children like she would like, get them to school, get them to soccer practice. She's not helping out around the house as much, even though her husband works 60 hours a week. He doesn't have time to come home and always help out around the house, and she can't even always manage to do the dishes or have dinner prepared. So this is making her feel really guilty. She struggles to think and concentrate, and even struggles with minor decisions like what to wear that day or what to cook for dinner. But she does not have any thoughts of death or suicidal ideation at this time. She has absolute clinical distress and difficulty with social situations, with her occupation as a homemaker, and just with her general overall ability to function. And as far as we know, this is not attributable to any other substance or any other medical condition thus far. Looking at other comorbid conditions, including anxiety, she does worry most of the time about whether or not she is able to provide for her family and play her role in the family unit. And she's also worried about doing activities because she's afraid she won't be able to do them and then will get kind of stuck or abandoned and get into a bigger medical problem. She does find it difficult to control the worry, even to the point at which she sometimes is merely sitting on the couch and resting or watching TV, and she feels anxiety kind of bubbling up within her. She often feels restless or sort of amped up. And in fact, the word she used to describe that is wired but tired. The more tired she gets, the more amped up and hypervigilant she feels. Of course, she gets very easily fatigued, has a lot of trouble concentrating, notes what she calls brain fog. She's irritable, she can snap at her husband, and that's never been a part of her personality until she started feeling ill. She notes a lot of muscle tension, and particularly in her neck and shoulder girdle, where she carries a lot of that tension, though it's more than she recalls in her younger years. And she has absolute sleep disturbances. She can't fall asleep. She wakes up frequently, and she finds that she is restless, tossing and turning, moving her legs, never getting comfortable, and always wakes up, no matter how much time she spends in bed, always wakes up feeling unrefreshed. These symptoms do cause significant distress and impair her functioning. And again, we don't believe that she is using any drugs of abuse, and we haven't recognized any other medical conditions, and in particular hyperthyroidism, that could be contributing to these symptoms. Continuing to look at other comorbid conditions, when we look at, in general, somatoform disorders and conversion disorders, there are several subtypes that have been identified. Psychogenic non-epileptic seizure obviously is applicable here. But I wanted to go through some of those other subtypes. And the second most common is weakness and paralysis, which is described in about 31% of patients with these disorders. She does have a history, sorry, there's no check mark there, of occasionally dropping things. She notices that the fine motor movements in her hands are generally coordinated, but occasionally when she's trying to write something down or when she's crocheting, that she will drop the crochet needles or the pencil after a certain level of activity. So maybe after 5 or 10 minutes of writing or crocheting, she starts to have issues there. She does have weakness in both of her legs, but these are not hemiparetic symptoms. The weakness definitely seems worse when she tries to stand from a sitting position or when she's standing in lines at the grocery store, at the post office, things we don't do anymore with COVID-19. She does note that she experiences these rising up of anxiety feelings that are similar to panic attacks, and they do seem to be associated with the times when she feels most weak and shaky. And her overall weakness and symptoms in that regard do tend to wax and wane depending on the day. Some days are worse, some days are better. The time of day is different, and she can't really identify any triggering factors for these symptoms. Looking into another subtype of abnormal movement, she does note tremor, as we've talked about before, and she does have some very significant dystonia in her muscles that kind of waxes and wanes, but she does not have a gait disorder, myoclonus, or any psychogenic Parkinsonism. Looking at speech symptoms that define these disorders, she has had trouble with hoarseness and whispering, particularly on the days that she feels most fatigued and unable to get out of bed. She often will struggle with speech and can slur her speech a little bit or have trouble with creating or developing the words that she wants to say. So in other words, she knows what she wants to say, but she can't really get it out, much like a Broca's aphasia might be defined. But she does not have any abnormal vocal cord movements. She had been seen by ear, nose, and throat a few years ago in the past as part of her extensive medical workup and was thought to not have anything wrong. She does occasionally note a globus sensation when swallowing, and she absolutely endorses transient paresthesias and numbness occurring in all the quadrants of her body and skin. As far as visual symptoms are concerned, we're getting kind of the bottom of the barrel here of the subtypes, but she does notice blurred vision, particularly when she is accommodating from near close-up vision to far away or back, but no double vision. She does believe that she's had nystagmus. Her husband has noted this in her eyes, but she's never been observed to have it in an office or hospital setting. She does not have visual field defects or complete blindness. And then as far as cognitive symptoms, she absolutely struggles with all of the above: poor concentration and memory, poor fluency, which waxes and wanes, jumbling of her words, trouble finding the correct words, and occasionally starting a response and then just kind of staring off and not finishing the response, or totally losing her train of thought, even on simple conversations about her children getting home from school or about what to have for dinner. So going into one other additional subtype here is the depersonalization and derealization or dissociative disorder spectrum, which can also be associated with psychogenic non-epileptic seizures. And the core symptomatology here, going through, she does often feel detached from her own body, mind, and thoughts. Sometimes when she's laying in bed, she doesn't feel like she is within her own body or has control of her own body. She does have tactile and somatosensory distortions, although she does not have visual distortions. She does not feel emotionally numb. In fact, this has been of significant distress, as we've already talked about. She does struggle with recall, particularly related to time. And she's had alienation. She has not had, I'm sorry, alienation from her surroundings in any way. She wants to be more involved in her surroundings. The alienation has been because she reports she cannot participate in things going on around her. And then as far as personality disorders are concerned, she did not meet criteria for borderline personality, narcissistic, histrionic, or antisocial personality disorders. Didn't want to spend the time to go through that. So we're left with a patient that more or less, at least on the surface level, meets criteria for depression, anxiety, somatoform disorders, and potentially dissociative disorders, in addition to her presumed PNES. So from the patient's perspective, what we end up telling her is this: you're a perfectly healthy horse, except for those stripes. I wouldn't worry about those too much. We see them. You really just need some diet, exercise, and antidepressants. The PCP, on the other hand, is going, whoo, I was able to pawn this off on someone else. I don't know what to do with this patient. And then from the behavioral health specialist perspective, it sounds like, well, we've got a lot of work to do here, and there's going to be a lot of paperwork involved. So I wanted to talk about neuropsychological testing shortly here. This in PNES may reveal mild cognitive deficits, especially with attention and with working memory. Patients will frequently fail to recognize words that have been repeated on multiple occasions, but in the absence of a negative response bias. So it's not that they're trying to fabricate a false memory or make up words. They just don't remember anymore. They're like, I'm sorry, I just can't remember the 3 words you asked me to keep in my head. Many people argue that the emotional distress that may be underlying a lot of their symptoms is part of the reason that they have these deficits. But interestingly, some studies have looked at patients with temporal lobe epilepsy and found that they also have similar symptoms. Whether or not that's due to the fact that these with temporal lobe epilepsy are on anti-epileptic drugs, which can affect the cognitive functioning, whether it's due to neural damage from the traumatic brain injury, mesial temporal sclerosis, or whether it's due to something else is not really clear. And then there is the Minnesota Multiphasic Personality Inventory 2. This testing is sometimes done as part of neuropsychological testing, to my understanding. It's often remarkable for high scoring within the hysteria subscale, the hypochondriasis subscale, as well as somatic complaint scores in the restructured clinical scales. Risk factors include social isolation, limited family support, dependent lifestyle, rejection of the actual diagnosis of non-epileptic seizure, lower education level, chronic migraines, chronic pain syndromes, unemployment, receipt of Social Security disability benefits, lower IQ, absence of a formal treatment plan, and longer duration of symptoms or older age at onset of symptoms. And so I think that when we think about people who are likely to present with this illness, we're more likely to consider people from the bottom picture than we are of the top picture. It's sort of an inherent bias we might have. And you may recognize that our patient has some of these risk factors for a worse prognosis, though not all of them. It's interesting that there have been some small brain functional connectivity studies where they use connectivity density mapping, or FCDM, to collect voxel data and map out local and global density of connectivity. And they've actually suggested that there's disrupted functional connectivity between the following regions of the brain, including the frontal cortex, the sensory motor cortex, the cingulate gyrus, the insula, and the occipital cortex. So there may be issues both within those areas of the brain, but also in the connectivity between those areas of the brain, that they're not communicating as well due to lack of density of communications compared to healthy controls. And this data is actually thought to support the hypothesis that patients may be experiencing their alterations in their attention, their sensory motor, and their emotional systems by suffering a particular manifestation of dissociative disorder. Furthermore, decreased connection density within the occipital cortex has been found to correlate with the duration of non-epileptic seizure activity. And this is thought to reflect an adaptation in these patients for long-term hypervigilance and increased response to external stimuli. I highlighted that because I think that's something that our patient has been experiencing and reporting, and it may be relevant here. So now this patient not accepting the PNES diagnosis and saying, you know, if I could just take care of my fatigue, ended up finding this crazy guy over here at the Bateman Horne Center. And my perspective is that something else might be going on here. And oh, by the way, it's definitely not lupus. So at our center, one of the things that we might do in a patient presenting with non-epileptic pseudoseizure is something called the 10-minute Nasaline test. And this is actually a test that is particularly sensitive for detecting orthostatic intolerance or intolerance of upright activity compared to the supine position. So in this test, which was actually developed at NASA for astronauts who have a disrupted autonomic nervous system after spending time in an anti-gravity environment, is now used in our office regularly, actually with every patient that we see that has fatigue. And what you essentially do is have your patient lay down for 15 minutes. You obtain blood pressure, pulse ox, and heart rate data. You get 2 readings after laying down for 15 minutes in a dark, relaxed environment. You then provide an orthostatic challenge in which the patient leans up against the wall. So they're not even having to hold up the entire weight of their body. But they are having to remain upright. And then we measure those same vital signs, in particular the blood pressure and heart rate, every minute for up to 10 minutes, while also collecting data about what symptoms the patient is experiencing and reporting, and also looking at the extremities or the body for possible physiological changes. So we actually did a 10-minute Nasaline test on a 10-year-old female. We had her lay down and took blood pressure and a pulse there, and you can see her blood pressure was essentially 108 over 60 to 62, and an average pulse of 88 or 89. But I want to point out that there is a pulse pressure there, the difference between the systolic and diastolic pressure of 48 millimeters of mercury. We then provided the orthostatic challenge by standing this woman up against the wall, as was shown in the previous slide. And I think I actually got off on the minutes there, but as we stood her up immediately, her pulse shot up to 114. Her blood pressure stayed relatively stable, but she felt lightheaded, weak, and noticed chest discomfort. And as time went on, you can probably appreciate that her pulse continued to rise all the way up to a peak of 132. And her blood pressure, you can see the systolic pressures did drop, but the diastolic pressures rose. And in fact, they probably rose in more magnitude than the systolic pressures dropped. As time went on, the observers in the room noticed that the patient's feet became a little dusky and cyanotic. At 4 minutes of standing, she noted that she was feeling nauseated and sick. And at that time, the observers recognized that her fingertips were also becoming dusky and cyanotic. And then by 6 minutes of standing, she started to have a mild, almost rhythmic beating motion in the neck and the right upper extremity. And she defined that as her tremor. And actually her husband, who was in the room, said, yeah, this is what some of these seizure events looked like. When she got to 7 minutes there, you can see that her pulse pressure dropped all the way to 14 millimeters of mercury. The difference here between 92 and 78, and her pulse was 132. And at that point, she started to have impending syncope and was sort of slid down the wall safely. And the test was aborted at this point due to what we would call her seizure symptoms. So overall, during this test, which we didn't even manage to complete 10 minutes of, she had a heart rate increase of 44 beats per minute and a drop in her pulse pressure of 30 millimeters of mercury. So what is really happening here? When we put a patient upright after spending time laying down, there's a shift of blood flow of 500 to 750 milliliters of blood into the lower half of the body on standing. And so what happens is, as we get that venous pooling, we start to have a compensatory vasoconstriction so that we can maintain intracerebral blood flow. And if that compensatory vasoconstriction is not enough, we get a increase in our sympathoadrenal response in order to maintain that intracerebral blood flow. And if those interventions fail to maintain intracerebral blood flow, we begin to have different processes that have been defined as orthostatic hypotension, neurally mediated hypotension, POTS or postural orthostatic tachycardia syndrome. But we can also see in some people, despite all this abnormal physiology, that they maintain a normal heart rate and blood pressure. So in this particular patient, we're looking at the possibility of POTS here, which is defined by an increase of 30 beats per minute in adults, or for those of us who deal with adolescents, of 40 beat per minute heart rate increase with this orthostatic challenge, which she absolutely meets as an adult. And in fact, with a 44 beat per minute increase, she even meets the criteria if she were still adolescent. The decrease in pulse pressure is thought to be primarily mediated by rises in the diastolic pressure, as we saw in that test, and remains of equal diagnostic value during this test, and is definitely something to focus on if the test is done. It's critical to understand in this case, though, that a lot of doctors, even cardiologists, will say, oh, I know the diagnosis now, this patient has POTS. But POTS is not actually a diagnosis in and of itself, is at least an argument that we make. And instead, I think it really best represents just a clinical observation of how we're reacting to the orthostatic challenge, how the patient is reacting. They increase their heart rate, they have pulse pressure changes that are compensatory to the actual insult, which is not having enough cerebral blood flow in this case. And so in this case, the physiological challenge is triggering compensatory responses that are different in different people in order to maintain cardiac output and cerebral perfusion pressure. It's important, this just briefly, that we do this test for a full 10 minutes. I know when I was in internal medicine, we would do orthostatic testing immediately and then quit the test. But you see, if you do that, that even if you only go to 5 minutes, you can miss up to 27% of people who have severe POTS. And even at 8 minutes, you'll miss 10%. It takes a full 10 minutes to get sensitivity with this test. And it's very important to also point out, just because a patient has had standard tilt table testing is not standardized actually across different institutions. And in fact, I can't tell you the number of times I've seen negative tilt table tests with completely remarkable Nasoline functioning. So we definitely believe that Nasoline is much more sensitive for detecting these kind of abnormalities. So we have a recent study that was just published in which the transcranial blood flow was measured with Doppler ultrasound upon orthostatic challenge when putting patients in a tilt table. And they noticed that in patients with the diagnosis of ME/CFS, or myalgic encephalomyelitis chronic fatigue syndrome, that there was a 26% decrease in their cerebral blood flow compared to a cerebral blood flow reduction of only 6 to 7% in healthy controls. More strikingly, though, was that they actually found that even in people who don't have these heart rate and blood pressure responses, there was also a 24% decrease in cerebral blood flow in ME/CFS patients. And so it's thought that past perfusion studies failed to recognize the cerebral blood flow reduction with their imaging modalities because these modalities were always performed in a supine position. But we have a lot of other studies as well that show evidence that there is actually a decreased cerebral blood flow during these events. It's not the same as a stroke. It's not an absence of blood flow. There is sufficient collateral circulation, but that there is sort of transient delivery of oxygen, nutrients, and ability to adapt to the exact cognitive task that is necessary. And it's believed that this altered cerebral perfusion is related to the orthostatic challenge, as well as other aspects, clinical aspects of dysautonomia that control the neurosensory, neuromotor, and neurocognitive deficits that we observe in patients with ME/CFS. Just briefly, inadequate cerebral blood flow has been associated with all kinds of symptoms: trouble with exercise, fatigue, syncope, unusual neurological symptoms that might be thought to be made up or not considered to be anatomically correct, diminished concentration, trouble with lightheadedness and blurry vision. And then we also see a resulting catecholamine surge, as we talked about before, when there's this decreased cerebral perfusion, and that leads to other other symptoms, including palpitations, shortness of breath, cold hands and feet, facial pallor, sweating, anxiety, chest or abdominal discomfort, tremor, and nocturia. And many of these, as you're very aware, kind of have some overlap in the patients we take care of in behavioral health. Complicating the assessment of these clinical findings is the fact, at least in ME/CFS, that symptoms induced from upright positioning or orthostatic challenge can be prolonged. And this actually removes them in time from the actual orthostatic challenge, which makes it even harder to recognize that there was an orthostatic challenge that induced the symptoms in the first place. And in some cases, these symptoms can last for several days after a particularly severe orthostatic insult. Also wanted to point out that we've done tests including validated NBAC task testing with tilt table. And we've noted pronounced cognitive delays, increase in testing errors, decrements in memory, decrements in concentration, and poor information processing that correlate directly with the degree of tilt that a patient is held up on. And we've done all kinds of additional cognitive testing with orthostatic challenge, and the data is pretty clear that cognitive performance decreases with orthostatic challenge in these particular patients. So going back to our patient, we were concerned that she might have some anxiety, but actually when you do the HADS anxiety score, she doesn't test positive for that. When we look at the HADS score for depression, she's borderline depressed, but it's not as high as maybe we might have expected based on her symptoms. We did an Epworth sleepiness scale, which is higher than normal. She does have daytime sleepiness, but it's not as high as you might expect for someone who spends all day in bed. And it certainly doesn't look consistent with something like obstructive sleep apnea as a potential contributor here. And then her FIQR for pain, for fibromyalgia, shows severe impairment of her function as is related to pain and pain symptoms. We also took a look at the SF-36, which is validated across multiple medical conditions. It looks at physical and mental components of health. And in our patient, it's sort of a way to look at what is contributing to her overall decreased function. So in this scale here, you see that the lower scores represent more severe symptoms. And I would point out that in her SF-36, she had very poor scoring on physical functioning, role limitations due to physical health, and vitality, energy, and fatigue, as well as pain and general health. But interestingly, social functioning is somewhat intact, but most intact remain the emotional well-being and mental health and emotional problems. So this is something we see all the time with people who are diagnosed with having psychiatric illness, depression, and anxiety, and then turn out to maybe have orthostatic intolerance or other symptoms of ME/CFS. You can see here, this is a comparison between ME/CFS patients on the different aspects of scoring in the SF-36 and those with other chronic illnesses, including CHF, depression, dialysis, and hepatitis. And you can see that in patients who are in their more ill phase of chronic fatigue syndrome, who are experiencing what we call post-exertional malaise that I'll talk about in a moment, their scores are mirror the, or even perhaps exceed the disability associated with these other conditions. We also look at the multi-dimensional fatigue inventory in our patients to try to see what's contributing to their fatigue and if that might be relevant in our evaluation and management of the patient. In this patient, again, highlighted in red, in this case, the higher scores represent more dysfunction. And she notes a lot of general fatigue, physical fatigue, and reduced activity, but motivation for activity remains. And her mental fatigue is elevated, but not as elevated as the activity levels. So with all of that, I wanted to talk a little bit about this illness, about ME/CFS. And this is really the best diagnostic clinical criteria we have come from 2015, where the Institute of Medicine compiled a bunch of evidence-based data and created both core criteria and then other diagnostic features of this illness. My goal here is just to familiarize you with the diagnostic criteria, not to necessarily defend them all. There's definitely a high evidence base for it, and I would encourage people who have questions to go to the Bateman Horne website, where we have really in-depth explanations and links to things like the Institute of Medicine report that go over that evidence base. But importantly here, the core criteria include impairment of normal function that is accompanied by fatigue for greater than 6 months. And this is severe impairment of function. Number 2 is the concept of post-exertional malaise. And I will pause on this for just a second to say that this is really, to our knowledge, the pathognomonic criteria of this illness. There's no other illness that we have recognized that truly creates this phenomenon. And what it is it's a delay in onset of worsening of the entire constellation of symptoms that a patient might be experiencing after some energy challenge, whether that energy challenge be a physical activity depleting energy, whether it be a cognitive challenge depleting energy. Obviously the brain requires a lot of glucose, or even an emotional challenge, be that a positive or a negative challenge. So some people can get really excited about, I don't know, the onset of Christmas and their family visiting, and that alone depletes their energy stores. And when they exceed the energy that they have in order to do tasks, when they exceed the ability to do that, they enter what appears to be an anaerobic metabolism. They have a reduced ability to create a VO2 max on exercise studies, and all of their symptoms get severely worse. And there's usually a delay in onset. It can be 12 hours up to 72 hours after the initial insult before these symptoms kick in. They're most severe. Nearly all patients have unrefreshing sleep that can be defined by insomnia, frequent nighttime awakenings, but in particular, everybody has issues with unrefreshing sleep. And then as the criteria define it, they must have either cognitive impairment, sort of as we've defined already, trouble with word finding, trouble with attention, concentration, and focus, trouble with social functioning, sensory sensitivities, decision-making issues, etc., and then orthostatic intolerance, which is really defined by autonomic nervous system dysregulation. And we sort of touched on the orthostatic intolerance component as well. And I've come to believe personally that if we knew how to measure these things better, that we actually find both of these in just about everybody with ME/CFS. Additional core symptoms include chronic pain, dysregulation of the immune system, infections, recurrent infections, or immune-mediated responses that mimic infection, neuroendocrine manifestations, and even neuroinflammation, which we define as glial cell cytokine release, elevated lactate, elevated temperature increases in the brain, generally in areas like the thalamus and the HPA axis, rather than talking about the cortex and the kind of things we see with multiple sclerosis, meningitis, encephalitis, etc. So those are found often in patients, but they're not part of the way to define this population from other people suffering from other illnesses. And then ME/CFS, if it weren't complicated enough, has all kinds of comorbidities. We've touched on POTS, orthostatic hypotension dysautonomia. There's a high frequency of small fiber polyneuropathy and peripheral neuropathies. Many will meet criteria for amplified pain syndrome or fibromyalgia, as well as central and peripheral pain sensitization. There's often neuroinflammation. We see mast cell activation syndromes, chemical sensitivities that don't always make sense, food intolerances that are not consistent, chronic idiopathic urticaria, high incidences of allergic rhinitis and what we define as exercise-induced asthma, but really it's more like asthma with physical activity or upright position. We can get viral reactivation syndromes, chronic migraines, other chronic headache syndromes, all kinds of gastrointestinal symptoms, including impaired gastric motility, irritable bowel syndrome, SIBO, and even celiac disease, lots of chronic sleep disorders, and even autoimmune thyroid disease, subclinical hypothyroidism, or euthyroid 6 syndrome. So with some of this information, I wanted to go back and look at our patient again through this lens. So going back to the questions of depression, we had said that she does have depressed mood nearly every day. And the way that we tend to interpret this is that this patient is mourning her loss of independence, her loss of function, both physically and cognitively. She wants to participate in things, but is feeling the impact of the enormous functional changes in her life. She still has interest in doing things. Her weight gain, despite decreased reports of decreased intake of calories, actually is what we see in ME/CFS. They have very strong evidence for a decreased metabolic rate and a quick conversion from aerobic to anaerobic or less efficient metabolism at the level of mitochondria and cells. And so people's metabolic rate can really decrease. And they can also notice huge changes in their hunger overall. The insomnia or hypersomnia is a function of part of the illness, and the spending time in bed may not actually be time spent sleeping, but time just spent in the supine or recumbent position and unable to participate in other activities as opposed to directly sleeping. The psychomotor agitation may indeed just be slower movements and careful movements in the setting of orthostatic challenge and reduced energy reserve. Fatigue goes without saying. The guilt makes sense because she used to be more functional for her family, her friends, and now doesn't have the ability to play that role in her life anymore. We've talked about the cognitive concerns in ME/CFS, and clearly there are impairments in her function once again. So In this light, we may argue that she, especially with the lack of anhedonia, may not be as depressed as we thought, even though there's clearly some issues here with her mood. Looking at anxiety, as far as the excessive anxiety and worry occurring more days than not, well, she's certainly worried that if she were to go out to the grocery store and have an attack where she couldn't stand up and she had to slide down onto the floor, felt dizzy or nauseated, that'd be particularly embarrassing. How would she drive home? There's anxiety about that every single day for her. She finds it difficult to control the worry because there's an unpredictability to her symptoms, and she wasn't even always aware that orthostatic intolerance was triggering her symptoms. And in fact, part of the hypervigilance and the neuroactivity that we see in this illness seems to be related to an increase in sympathetic activity, believe it or not. Even though patients are tired, they tend to have an overemphasis on sympathetic fight or flight symptoms as opposed to those in the parasympathetic pathways. And in fact, a lot of times on exam, you'll see that these patients have particularly dilated pupils, even in a room with bright fluorescent lights. She often feels restlessness and on edge. That's the sensation she describes as wired but tired. And we frequently recognize in these patients that the more exhausted they get, the less energy reserves they have, the less regulation they have between sympathetic and parasympathetic activity, with a shift towards feeling more wired and more hypersensitive and hypervigilant. Fatigue, again, goes without saying. Decreased concentration goes without saying. Irritability is part of that hypervigilance that we will often see. And the muscle tension is not an uncommon symptom. People just hold themselves in these tight positions. And the studies that we've done thus far do suggest that there is certainly a lot more firing at the neuromuscular junction. And this may be mediated not just by the central nervous system, but by the peripheral nervous system as well. And so sometimes muscle relaxants, and in particular benzodiazepines, are helpful for patients because of that peripheral impact that they have as opposed to a central impact. Sleep disturbances may be related to her underlying illness and the core feature of her underlying illness as opposed to anxiety itself. Although as the day goes on and as people deplete their energy, they do get more wired but tired. And so often they'll feel the peak of their kind of sympathetic overdrive at nighttime, right when they should be winding down to fall asleep. And in this case, we may argue that there is another medical condition contributing to her symptoms. Looking at conversion disorder and somatoform disorder symptoms, again, may not be non-epileptic seizure, depending on how you want to define what she experienced during her orthostatic challenge. The history of dropping things may be related to energy and concentration and focus as well, with fine motor movements when using a crochet needle, when using a pencil. But we see that that's not infrequently in our patients. The weakness in the legs may be related to specifically to lack of circulatory efficiency in the leg muscles, lack of ability to effectively use oxygen for aerobic metabolism and to generate ATP at the level of the muscles, and just a core feature of the fatigue we see in this illness. Panic attacks, again, kind of fit into the hypervigilance aspect of the illness. And the inconsistency of symptoms really is related to positioning, is related to the existence of post-exertional malaise. Is this a good day or is this a day where symptoms are highly active? Among other features in the surrounding environment. Are there lots of bright lights, lots of sounds? Is there lots of sensory input being processed all at once? That's a very energy depleting task. The abnormal movement is likely related to her orthostatic tolerance, and the dystonia may be again related to the neurological changes we see in this illness. Speech symptoms probably related to the orthostatic intolerance, decreased cerebral blood flow. And the hoarseness and whispering is actually something we generally will see during post-exertional malaise, and is actually often accompanied by sore throat, a little bit of myalgia, arthralgia, flu-like symptoms, and tends to look like viral reactivation during those periods of post-exertional malaise. Even though we don't always detect viral reactivation, it might just be that the immune dysfunction of this illness is responding as if there were a virus. And then as far as the sensory symptoms are concerned, that may also be an issue with the small fiber polyneuropathy that we sometimes see in these patients, as well as circulatory issues to those involved nerves. And of course, that is transient and dependent upon position and other energy expenditures throughout the day. visual symptoms. Again, cerebral blood flow likely playing a major role there. We do see nystagmus, not infrequently, that is not consistent and not always reproducible. And then the cognitive symptoms, I think, go without saying, but certainly we look at this in a very different light, knowing that there's not efficient blood flow in the brain. So I was looking on UpToDate as I was trying to refamiliarize myself with conversion disorder and somatoform disorders. And I did want to point out this particular graph, which caught my attention as an ME/CFS specialist. And this is specifically aimed at describing the arc of symptoms, or sort of the arc of a presentation of someone with conversion disorder. And my brain just screamed that this could be ME/CFS when I saw it. Many cases of ME/CFS start with people who are relatively asymptomatic or have minor symptoms. And then there is a trigger, a very stressful trigger, whether it be a bad infection. That infection can be Epstein-Barr virus, or like we've seen recently, COVID-19, can be a car accident or some other traumatic event that activates their stress response and or makes them ill. And of course, you see an increase in symptoms when they're ill. They spend a little time off of work. Maybe it's a prolonged illness. It takes 3 weeks for them to get back to work. And then they work hard to try to get better, but they recognize, you know, something's just not right. I'm not totally getting better. I get a little better, but I'm not totally better. Then another stressor comes on while they're still in this perhaps altered physiological state. Doctors are looking at them, the labs look normal. There's definitely nothing wrong with them, right? Well, a car accident comes along, or some other infection comes along, or the death of someone's grandmother comes along, and all of a sudden that's sort of the straw that breaks the camel's back. And from that point on, the person is no longer able to function at their same level. And they start to meet criteria for what we would define as ME/CFS. Not always. I'm not saying this is always true in conversion disorder or somatoform disorders, but we may be missing it occasionally. And these patients then spend time off of work because they can't function. Their lack of functioning is hard to define. Doctors tell them they don't know what's going on. Then they start to have marital problems. They're not helping out around the house. The spouse may not understand what's going on with them either and says, well, the doctors say you're just depressed. The doctors say this is all in your head. You need to fix this. That can create a lot of issues. So I just wanted to point this out to say that, you know, it's something to certainly think about when you see this arc of symptoms, that there are definite conversion disorder cases out there, but I've seen more than a few people come to me with diagnoses of conversion disorder, including from Mayo Clinic, and then be found to have Nassauline exams, and like the one we showed, and have true post-exertional malaise that we can measure.
Dr. Yohan?
Yes?
We only have about 5 minutes left.
I am very close to that. I will skip this slide. And I just wanted to touch on one more thing for our presentation here, and then leave some time for questions if I may. So we mentioned, didn't our patient also have Raynaud's in her history, and wasn't her ANA 1 to 80? Couldn't she have lupus? And I did want to point out that she had this finding on exam. So it's a macular erythema without a texture, it blanches to the touch, and it was warm to the touch. It was not well demarcated, poor margins, not painful, but it was itchy. She had no associated fevers or leukocytosis. She had not experienced improvement with antibiotics. And the question was, could this be autoimmune? She had a skin biopsy for this finding, and there were no findings of neutrophilic or lymphocytic infiltration recognized, no interface dermatitis like we see in lupus or dermatomyositis on immunofluorescent stains, no organisms, but they did find decreased innervation of the skin by small fiber nerves. And this is what we would refer to as erythromelalgia, not Raynaud's. And I wanted to talk just really briefly about small fiber polyneuropathy, which occurs in at least 40% of fibromyalgia patients, as well as 40% of ME/CFS patients. We diagnose it or find it on skin biopsy by a decreased density of small fiber nerves. And it can be associated with underlying systemic illnesses, not just with sensory symptoms. A skin biopsy is the gold standard for diagnosis of this test, and you will not find small fiber neuropathy on traditional nerve conduction studies. Here, we're just pointing out that there are afferent C fibers, A delta fibers, sensory fibers that are involved, but it can also involve postganglionic sympathetic autonomic axons. And these are all nerves that are small in diameter and are innervating most organs and tissues. And here you can see it controls pseudomotor and pilomotor responses, as well as sensory responses. And it's also, this stain here shows that there's a loss of axonal innervation, often in people who have a positive skin biopsy, in their myovascular structures, in their actual blood vessels, the arterial structures in these small fiber neuropathies. And so what does this lead to? This can actually lead to, this loss of innervation can lead to arteriovenous shunting of blood, where we actually skip the capillaries and muscle tissues and don't get exchange of oxygen, of nutrients, of metabolic waste products. And that is in this graph here on the right, definitely higher in fibromyalgia, though we haven't repeated this yet to study in ME/CFS. And so what's interesting about that is these autonomic functions that are being affected by small fiber neuropathy control heart rate response to deep breathing and Valsalva. They control sudomotor sweat responses, heart rate and blood pressure responses to tilt, and even gastrointestinal function. So again, lots of overlap with the kind of symptoms we see in people with anxiety and panic attacks. And in particular, I thought it was important to add one more possible diagnosis that people in behavioral health see, which is gastrointestinal disorders for which they don't find a cause. So the gut is densely innervated by these small fibers, and we get all kinds of digestive symptoms in patients with ME/CFS, including GI dysmotility. We see postprandial nausea and vomiting, GERD, lots of anorexia and cachexia, and that can be associated with weight gain or weight loss, depending on the particular patient. Diarrhea, constipation, and irritable bowel syndrome. But in particular, I have seen several people with the diagnosis of anorexia nervosa, bulimia, because of lots of nausea and vomiting and decreased food intake, who end up having severe GI dysautonomia as an underlying explanation for their symptoms, and that improves with treatment. So in our patient, to not waste any time, we taught her to pace. We treated her orthostatic intolerance. We treated her for small fiber polyneuropathy. We used clonidine to help with hypervigilance symptoms, treated migraines with CGRP antagonists. Lorazepam was helpful for her symptoms of, quote, panic attacks and hypervigilance, used much in the same way that is used in the behavioral health field. Gabapentin decreased her restless legs and helped her sleep. And she basically went on to have some improvement in her symptoms, no longer having non-epileptic seizures. She would tolerate about 4 hours of upright activity daily. Her brain fog and cognitive symptoms are measurably improved, though not resolved. Sleep is more refreshing, and her pain score is reduced to an average of 4 of 10 hours daily. So with that, I hope I left time. I know it's running late here, but for some questions about this illness or about this presentation.
My question is, it's kind of beyond dispute that emotional trauma in early childhood contributes to psychiatric conditions.
For sure.
And that's because of upregulation of cortisone pathways or whatever. It seems like, from my experience, that a lot of psychiatric patients also could have these kinds of conditions. And I was curious if you had any thoughts about whether or not trauma has something to do with the way that the nervous system is organized in such a way as to predispose a person to this kind of problem.
Yeah, so this would be speculation, but certainly we have observed that many patients do have some sorts of trauma in their backgrounds, and that can vary widely. One of the risk factors we identify for development of this illness later in life is traumatic brain injuries in particular, and also motor vehicle accidents that create whiplash and actually sort of create some anatomical issues in the setting of hypermobility that we define as craniocervical instability. So there may actually be compression on the brainstem from those. But outside of those type of traumas, if we're talking about specific emotional traumas, certainly we've recognized an increased incidence of that among our patients as well. And that may be one of many risk factors in a susceptible population that eventually lead to ME/CFS. I think that, I hesitate to say this, but I'll say it, it's one of the hypotheses that we sort of have about this illness is that you take a susceptible individual, whatever that may be defined as, and you provide a lot of stressful inputs in these neurological circuits, whether those be viral illnesses, whether those be emotional trauma, whether those be physical trauma, whatever the case may be. And they add up and they ultimately sort of trigger what's been defined as a sickness response. And there are some people who hypothesize that this sickness response, with decreased metabolism, with the feeling of flu-like symptoms, with fatigue, that's sort of evolutionarily conserved, it gets turned on and it just never seems to turn off for whatever reason. And so these symptoms persist, and then they have secondary downstream effects on the immune system, on the neurological systems, both peripheral and central, metabolomics that become more permanent. And then we start to see these secondary complications and other comorbid conditions as a result. And while we obviously can't prove that, that's certainly an appealing hypothesis to me, and I think is one way to possibly explain the increased incidence of those type of traumas in ME/CFS, but also in psychiatry in general.
There's a question in the chat. If I don't know if you're able to see it, Dr. Yelman. It says, how often are pseudoseizures diagnosed in mental health patients?
So that's a really good question. And in fact, we at the Bateman Horne Center have posed that question and wondered about how we might do investigation on that specifically. But to my knowledge, a study has yet to be done in this case. And I think it's something that's certainly a future direction for us. But I will say in my experience, and of course, people who come to our center are screened, there's inherent bias about who we see as patients. But in my experience, there's a really high proportion of people with pseudoseizure who end up having some sort of unrecognized orthostatic intolerance, that when you improve those orthostatic intolerance symptoms by a multitude of treatments that we didn't discuss today, that those symptoms improve. So it's definitely not insignificant, but I don't have direct numbers for anyone today.
Dr. Yelman, so for a patient like you had described, you know, she was on a stimulant medication and she had all these other symptoms, and then she was in bed all day. Normally, if it were my normal psychiatric patient, I would say probably need to be more active, get out of bed, do sleep hygiene. Maybe we can clean up some of your med regimen. You know, how would you approach a person like this? Do you automatically send them to the Bateman Horne Center, or do we try to work on these other things first?
Yeah, so I think what you're touching on, it goes back to the idea that people with ME/CFS, this is a chronic condition with no cure. And so the best we have is the ability to kind of look in at individual symptoms and treat the ones we have most control over. So I absolutely agree with you, Dr. Lin, that looking at things like sleep hygiene, cleaning up the medication regimen are a huge part of what we also do. And we would love your assistance in that with these type of patients. As far as exercise and getting up and participating more, that is a particularly tricky problem in ME/CFS. And there are studies here, well, there's some bad studies, but the more recent studies show that people actually cannot tolerate getting up and doing exercise at their most severe symptomatic parts of this illness. And so we actually have to help treat their orthostatic intolerance pharmacologically with fluids and salt, et cetera, and treat some of the neurological hypervigilance first before we can start having them do very graded exercise regimens. And I've had success for people do very, very slow, very minor, often recumbent or supine exercise programs, as long as they're very careful with their pacing and how they introduce it and taking appropriate breaks and making sure they're doing it when they're not at their peak of symptoms and when they're not in post-exertional malaise. And so in those cases, they can show improvement. And in particular, isometric exercises, yoga, core strengthening tend to be helpful. And also people will use wearable devices to monitor their heart rate. When their heart rate starts to spike, even before they feel bad, it's often a sign that they are physiologically stressed and a sign that they need to take a break and relax until it comes back down to their baseline heart rate. Those are the type of exercise routines that help people the most. But often as an initial recommendation, it tends to be more harmful than helpful. It puts people into post-exertional malaise, in which case they cannot experience symptomatic improvement. So it's a very tricky question. And then a lot of doctors will argue, and it's a fair argument, that the more time you spend recumbent or in bed, the more decompensated you become. You have less of a vascular pump in your leg muscles, and that actually contributes to orthostatic intolerance. And that's absolutely true, but it doesn't change the limitation of the energy envelope when people present very sick. And so we have to work on some of those other aspects first. As we improve those other aspects, we can then start introducing more upright activity, and we definitely do as part of our treatment regimen. Sleep hygiene is incredibly important, but also incredibly hard for these patients. To the topic of the stimulant therapies, that is different ME/CFS experts have different opinions on those drugs. Certainly people who are students or who are still able to maintain maybe small part-time work, or who are taking a final exam, or even for patients who just want to go see their doctor, using a stimulant on an as-needed basis can be a way to get through that encounter when they may not otherwise. but I personally don't feel that regular daily use of stimulants is helpful. It certainly can make a lot of those hypervigilance symptoms worse, but in addition to that, it almost forces people to use more of their energy envelope, more of their energy stores than they would otherwise for the activities that they're participating in. Even staring at a wall on a stimulant therapy is more energy draining than doing so otherwise. And so I try to reserve it for very special situations, but not make it a regular part of therapy.
Thank you, guys.
Thank you, everybody, for your attention and this opportunity.